the settings now. We still use infliximab in JDM, and for skin rashes, hydroxychloroquine and sunscreen. And that's something that I forgot to mention about lupus as well. So sunscreens are very, very important both in JDM and lupus. So a lot of time we have seen our patients coming back from their holidays or coming back from visiting their family from India and Pakistan, and their lupus and their JDM flares up significantly. And that's usually because they are enjoying their life, holidays, so they forget to put sunscreen. And compared to UK, where before we came to Karachi for 15 days, we haven't seen any sunshine. In Pakistan, you will be unlucky if you don't see sunshine every day. So sunscreen is very, very important, not only to prevent the flare-ups as well as to prevent the cutaneous lymphomas. And that's it. I was told that I have 2 minutes, so if you want any questions. Yeah. Yeah. Yeah, there are guidelines available, and certainly I can share guidelines with you from our institute. But roughly I can tell you the dose of cyclophosphamide that we use in pediatric population, in pediatric rheumatology population, is significantly smaller than oncology population. So we use 375 milligram per meter square as intravenous infusion with hyperhydration, and then we increase it to 500 milligram per meter square with the maximum dose of slowly increasing to 750 to 1 gram, and we tend to keep it to 5 cycles, and we keep a cumulative record of the cyclophosphamide dose. But this is, if we only give 5 cycles, this is really a small dose. However, it is important in teenage girls to think about fertility, both boys and girls, but more important in girls. So we have a close collaboration with our gynae colleagues, and when we offer cyclophosphamide to our teenage girls, and boys, we offer them to have their sperms and eggs frozen, and therefore if in later life, if they have any issues, that can be used. It's not a universal practice, but it's something that can be used, especially in very worrying patients. Yeah. Yeah. Okay, so it's a good question. I think the better answer I can give in Urdu. कि जब आप जो है मक्खी को हाथ से मार सकते हैं तो आपको तोप चलाने की ज़रूरत नहीं. I'll come to the answer. So we don't keep lupus patients on lifelong treatment. If they are needing treatment for longer period, that's the failure of treatment. So you need to escalate the treatment. Now you need to know why we give intravenous immunoglobulins and plasma exchange. So intravenous immunoglobulins and plasma exchange are transfusions. So they only get rid of circulating antibodies. They are not bone marrow transplant. So if you want to get rid of disease, then bone marrow transplant is the answer. But you have to weight the risk and benefits. Bone marrow transplant on its own, so you won't do bone marrow transplant for any patient with lupus because you are worried you're going to give them steroids for 10 years. But you will do bone marrow transplant on a patient who have failed steroids, DMARDs, cyclophosphamide, rituximab, because you have to justify your decision. These treatments, even IVIG, plasma exchange, they come with a serious risk factor of losing your life as well. So plasma exchange and IVIGs specifically, they are not, they are rescue treatments. So they only help you to get rid of circulating antibodies when you are in a crisis. They do not cure lupus. If you want a cure for lupus, I'm not sure bone marrow transplant is the answer, but that's closest to the cure. Thank you.